Okay.
Good. Have you got the agenda to show?
Yeah.
Okay. All right, welcome, folks. This is my name is Bill Porter. I'm the moderator for today, and I welcome everybody. And it's great to see some familiar faces and some new ones. But I would like to go over the agenda and, of course, the welcome, which I am doing. And then we have an introduction of Mary Eicher by Pat. And then Mary Eicher is going to speak, and then we're going to have a nice break where you go out and stretch, you get food or whatever you want to. And then we're going to have Mary Eicher part 2. And before we start part 2, I'm going to address some situations before we get into part 2, but that will come after the break. And then we're going to have open discussion. And then we're going to have a wrap up with Pat and Judd. And then we're going to have a nice thing called overtime. It's when, especially if you have not been called on, or you have a question you want to ask and we missed you or something, in overtime, you have a chance to do that. But the 2 to 4 meeting is recorded, but overtime is not recorded. So that's so you can ask almost anything. Anyway,
that's important.
You will find this a very caring and supportive group. So we encourage you to speak up if you have a question. And also during the discussion, we will probably open it up for new people to discuss who they are, what type of neuropathy that they have, and so on. But anyway, again, I welcome everybody, and I'm going to turn the meeting over to Pat to talk about our speaker. Pat?
Thank you, Bill. Hi, everyone. My name is Pat Gualtieri. I am the president of the Peripheral Neuropathy Support Network. I want to reiterate the appreciation to having everyone here today, and we're looking forward to a very informative session. We are trying something new. We're always trying to spark interest and add information to share. So we decided that we would show a pre-recorded presentation rather than a live speaker. It takes a lot of work to get a speaker and solidify the dates and everything. And we thought this was a great way to share a presentation that was well received in Pittsburgh at the Pittsburgh Peripheral Neuropathy Support Group back in April of 22. I am not going to introduce Dr. Eicher because one of the members of that group is actually her patient. Her name is Karen, and at the very beginning, she's going to explain her relationship with Dr. Eicher and who she is. Then we will have part 1, where we'll actually listen to the first 40 minutes of Dr. Eicher's presentation, which is basically about how you diagnose, identify, and work with your doctor once your diagnosis is made. So, Judd, if you will start, please, Dr. Eicher's presentation. We'll appreciate your feedback afterwards if you like this idea of a pre-recorded presentation. We think it's a way to share more information with more people.
Whoops. Let me get Dr.
practicing
Eicher
here
on
in
here.
this area because
Okay, he has to start it again. There we go. And we are, of course, not taking questions during this because this is a recording, but we will be in part 2 after the break. Open it up.
just like to introduce you to Mary Elizabeth Kovacic Eicher. She's a medical doctor, and she's with a fellow medical group. And her office is in the Greensburg Medical Commons building. Her primary specialty is neurology. Neuropathy on the brain, yeah. And it looks like she had most of her education at the Hershey Medical Center of Penn State, clear through from her MD to her fellowship. And on a personal note, she's been our doctor, my husband's and mine, for several years. Very attentive to our needs and follow through up needs too. Her and her staff have been great. They've gone above and beyond on all our recent things. So we greatly appreciate her and thank her for coming. And we'd like to welcome you and thank you for speaking tonight with us.
Absolutely. Thank
Add
you.
anything to that?
No, just, yeah. I'm actually local, so I grew up in the area. So our meeting tonight is in the Greensburg, Pennsylvania area, or Irwin, which is outside Greensburg. And I grew up in a small town outside Pittsburgh called Blairsville. So grew up with about a town of 3,500 people, and I've grew up in this town of, in Southwest Pennsylvania. And so my goal when I was studying was always to sort of go out, learn specialty care, and then bring it back to the area. So my plan was to always come home. And so I did my undergraduate at the University of Notre Dame. I did some graduate education. I did my master's in public health at the University of Pittsburgh, and then went to Penn State Medical Center, Penn State Hershey, for my medical degree, my residency in neurology. Are practicing here in this area because I feel like my patients have wonderfully been very receptive to talking to me. And that's so important. And it's so important to take the time to get to know each other. I like when my patients know something about me and something about my family. And I like to know something about my patients.
Uh-oh. Judd, we lost the volume.
I think there was a big jump in the tape too. I'm not sure. It looks like it jumped.
It did. Still muted.
I see anything, but often if people need a nerve or muscle consult, then some of my colleagues will send them to me. If we need even more help, we're very lucky because we have access to academic centers very close by. So people that have clinical, systems that have clinical trials available for some of our patients with certain nerve and muscle diseases, we can send them right into Pittsburgh. So I've been here now 2.5 years. Time goes fast and I love it and I wouldn't change anything. I plan to stay until Excella tells me I can't. But I always tease them about that. I really like the system and I really, when I was looking for a place to end up, I started just calling hospitals back here because I had told my parents and I told everybody I grew up with I was coming, I wanted to come back home. It was never about going to a big city or staying in Hershey, although it was lovely. It was about really bringing care here. Growing up in a town like Blairsville, you meet patients or you have friends and family that, we went into the city, but we didn't want to have to go into the city if we didn't have to. And it's that small town lifestyle that really drew me back here and what I love. And I love walking down the street and seeing people I know. I like going to church and seeing my patients. I like walking into the grocery store and seeing my patients because I think it's important that patients see that we have a dedication to the same town they're a part of and the same community they're a part of. And I'm really invested in the health of this community. And so part of my goal when I called around to different hospital systems was really finding one that shared those same values. And I have to say that Excella does. It's been a blessing and they've allowed me to practice medicine the way I want to practice medicine, which is to really focus on the patient. And they let me spend the amount of time I need to spend with people. And my patients all know I always run behind because you'll see tonight I talk a lot. And it's hard to make me quiet. But I like that because I like getting to know things about people. I like getting to know something personal about people. And that's why, I first went into medicine. I thought I'd do emergency medicine. And then I realized the next day I'd be trying to figure out what happened to the people I admitted to the hospital. And I like being with people from the beginning to the end. And, when things outside of our scope of practice happen or or patients unfortunately pass away, I appreciate when family members call me and tell me, because I want to be able to go and pay my respects too. And so I think in a lot of ways, this community has really allowed me to practice the kind of medicine I'd like to practice. And so I've gotten to know people like Karen and now Mr. Wilshire and others. And it's just been really, really wonderful. So I want to thank everybody for letting me come. So when Karen said, did you want to add anything else? I added a lot. but just in general, I wanted to be sort of relaxed during this talk and just in discussing everything with people. I know that you all either suffer from neuropathy or care about someone that suffers from neuropathy. And I really think the more we know about it and the more we tell patients about it, the more empowered patients can be. And so when I think about my patients, I really like to think about them as people and individuals. So everybody will experience neuropathy in a different way. When you hear about neuropathy, people will go online and say, what is neuropathy? Well, it's not just one thing, it's many things. The person to the right of me may say that in their neuropathy, they have numbness and tingling, but someone else might have severe, terrible pain. Someone else might have burning pain. Someone else might have stabbing pain. Someone else might get cramps and spasms. Someone else might just fall because they can't feel their feet, but they don't know they can't feel their feet. And so it manifests in very different ways in different people. And so every single person is going to experience their own version of neuropathy. And I think that's something I try to tell my patients right away, that there's not any one way to treat someone that's going to work for everyone. And I think that often is an approach we don't want to have. We don't want to say to somebody, okay, you have neuropathy. Here are the 5 things I can do for you. Have a good day, right? You want to know that there's always going to be hope, that there's always going to be an option, and that I'm not telling you, yes, okay, 1, this is going to change your life. Yes. But how can I help you live the life you want to live despite it? So you don't want to become, yes, it will be part of who you are, but you don't want it to be the only thing that you are. And it can be so cumbersome for some people, and it can be so devastating for others. It just depends on the type, and again, how it manifests in that particular person. So it's so important that we all know, and those who suffer from it understand, that it will change over time. There will be ups, there will be downs, there will be plateaus. There may be severe declines. There may be times when you feel a little bit better. The point is, sorry, is someone asking a question?
That's the question.
No, okay. I think the point is that no matter what, you're going to have somebody there with you to ask along the way. You need to know, and you need to have relationships with your providers, whether it's me or someone else, where you feel comfortable going to them with questions, where you feel comfortable saying to them, well, what you did last time was not so good. It didn't work. And that's okay. We're not offended. We need to know, or we can't help you feel better. Because again, not every one thing is going to work for every single person. So I know all of you have probably heard of gabapentin, and every doctor will say, okay, we're going to give you some Neurontin or gabapentin, and it's going to work. Well, not for everybody. And some people can't tolerate certain medications, and there'll be side effects. And our job is to let you know what to watch for, what to know. Okay, it might be working, but your feet are now 5 times bigger and you've gained 10 pounds. Well, that's not helping you walk better, right? Or, okay, yeah, my numbness and tingling or my burning pain is much better. I sleep better at night. Thank you. But I can't think of words during the day because my mind is so clouded. I just want to go to sleep. Well, then that's not a good medicine for you. And I'm not saying gabapentin doesn't work. It does in the right person. And so that's why I wanted to share this list with you. This was shared with me when I was in my training, and it's something I carry in my pocket. So that's actually a little size pocket card that I have in my top drawer, and everybody in my office knows where to find it. And though I've copied it for them, they still come for mine. And love this because on one side, it gives you some options for topical treatments of neuropathy. And then on the other side, it gives you many, many options for oral or medications that you can take for neuropathy or neuropathic symptoms. And it's incredible because some of these medications you would never think, and some of them, like one of them listed on there is topiramate or Topamax. One of the side effects of Topamax is numbness and tingling. Yet, right, here you go. Yeah, but in some people, it actually helps their neuropathic pain. And the numbness and tingling isn't the problem. The problem is the discomfort or the pain. So every single medicine works in a different way, attacks a different pathway, deals with neuropathic pain in a very different way. Neuropathic pain is not the same as when right before I got here, part of the reason why I got here just in time was my son, who's 3, one of my sons is 3, stubbed his toe on the way and he actually cut it. That kind of pain is very different than neuropathic pain. That pain happens, is terrible, but it's over very quickly. The kind of pain that we have in neuropathy doesn't like to go away, right? It's sort of, and it can be nagging. I feel like that's a really good word sometimes for what some patients experience because it gets so old to have to deal with that same pain all the time. And it certainly is hard and not fair for me to speak like I know what it is because I don't. And so for one of the things I learned in training and one of the things I really try to say to people is I try not to say, I know, because I don't. I don't know what it's like to be in your shoes. And I don't know what it's like to experience that pain. Now, someday I might, but right now I don't. So I can tell you what I read in the books, but you have to tell me as best you can what you feel and what you experience. So I can try to figure out what I know, what I've been given to try to help. So a big part of what we say, or what I like to say is, no matter what the problem, there's hope that we can help you. There's hope that we can help you live the life you want to live. But sometimes it takes time to get there. And that can be certainly frustrating. And I think it's important that as providers and the doctors that you see, that they let you know that they say, this is something that'll be lifelong and we're going to deal with it together. And it's not that they'll make mistakes, but we may choose the wrong path sometimes and we may have to go back a few steps to get you back where you were and then try again with something else, because there is no clear-cut fix-all. In some neuropathies, in very few, unfortunately, there may be. So we say when we talk about neuropathy in general, there are many types of neuropathy. But when we think about neuropathy, it can affect 2 different parts of the nerve. So the nerve is made of the main part of the nerve, and I'll use my arm. You've probably seen me do this before. But the arm is the axon or the nerve itself. The myelin is the sheath around it that protects the nerve, and it actually doesn't really look like a sleeve. It looks like bands around the nerve. There's little spaces between them, but it's an easy concept to think of myelin or that protective sheath as a sleeve. You can get damage to the myelin, or you can get damage to the axon or nerve itself. The most common type of neuropathy that most people experience is the kind that affects the nerve, this kind. And that's treated in all those different ways I gave you there. The reasons for it are countless. And so that can be one of the most difficult and most challenging things, not just for us as providers, but for you as patients. Well, why did this happen to me, Doc? I don't know. And in so many cases, it's because somewhere in our DNA, it's written that someday we're going to have neuropathy. Runs in our family, or we're prone to it because of a certain history in our family. We don't know. And some of you have probably heard your providers say, okay, in 66% or in 2/3 of you, I'll figure out what might have led to this or what might be causing it, like diabetes is a simple answer sometimes for people. But in 33%, we don't know. And it's called idiopathic neuropathy. I don't like that term because of where it comes from. It means we don't know. but there are certainly still things we can do for it. And so one of the first things we have to figure out is which part is it attacking, because the treatments are different. If you have something that attacks the myelin, usually those types of neuropathies tend to be much more aggressive, rapidly progressive, and so aggressive, rapidly progressive, and sometimes, most often, require an IV treatment or a pill that actually immunosuppresses you. So it can be almost like an autoimmune disease. So if you've heard of things like Guillain-Barré, it's like a long-term or chronic Guillain-Barré syndrome. Now, Guillain-Barré also can attack either this part or this part. So when we treat that in the hospital, that becomes more complicated because we have to figure out which part of the nerve is being attacked. But when we think about chronic Guillain-Barré, we're often thinking about what attacks the myelin. That's called CIDP, if any of you have heard of that or been diagnosed with that. That can be a much more aggressive, much more progressive, and much more difficult thing to treat. Though both are very difficult to treat symptom-wise, it can be hard to slow that down. And that can very quickly put someone into a wheelchair. So that's different. And it's important that we say that to patients. Say, you don't have that kind. So if you look it up and you see that, that's not you. And that's important to know too. In other cases, I think knowing, so the most common type is going to be that one that attacks the nerve. And that's the kind that we think about. So diabetes is a difficult one because it can actually attack this part, and these are both types. They're called large fiber neuropathies. Then there's this whole other part of neuropathy called small fiber neuropathy. And so if your large fibers are okay, sometimes it's the little tiny fibers. And you're not diagnosed until someone takes a sample of your skin and looks at the number of nerve fibers. So I don't know if any of you, I'm sure many of you have experienced an EMG or a nerve conduction study, that thing where the doctor zaps you and pokes you with a needle. Okay, I do those. They're very helpful, but they only look at the large fibers. So if I see a patient and I say, well, it's normal. And they say, well, I have numbness. That means I don't have neuropathy? No, that's not what that means. That means I can't see it yet because the first nerve we test is about halfway up the leg. And if somebody has numb feet, we're not going to see it yet. But sometimes it's because you don't have a classic neuropathy where we attack this, or this. In the large fibers, it's actually attacking the very smallest nerve fibers in your skin. And that can happen in diabetes also. It can also happen classically in a lot of autoimmune conditions. If you've heard of things like lupus or Sjogren's disease, you can see it there. You can see it in tons of different conditions, hundreds probably, but many that we think of that are autoimmune. So when we think about neuropathies, one of the first things to think about is it a large fiber or is it those smallest fibers that are being affected? That's often when someone says their neuropathy, if any of this affects any of you, it's patchy. It'll come and go. It'll be like electrical zapping. And people will say that and think, this person doesn't have anything. Oh no, they do. And you can prove it with a sample of the skin. So it's a skin biopsy to look at the small nerves. You look at actually the density. Someone sits and counts under a microscope to look at how dense the fibers are. And that can be attacked also for a number of different reasons. So you're trying to figure out, okay, is it small fiber? Is it large fiber? If it's large fiber, is it the axon or is it the myelin? Then once you figured all that out, what's doing it? Do I know or do I not know? So initially there's a whole slew of lab testing that we suggest. We look for things like diabetes. We look for glucose intolerance. So people who have not yet developed or had a diagnosis of diabetes, but years before can have glucose intolerance and be close to diabetic, can start to get neuropathic symptoms. One of the most common, and this may have affected many of you, is B12 deficiency. So we look at B12 level. On the other hand, B6 toxicity. So too high a B6 level can do it. Too low a B12 level. There are things, like I said before, autoimmune conditions, things like Sjogren's or lupus. So sometimes we screen people for that. We screen people for blood disorders where you have a certain amount of protein in your blood. If you have too much of a certain kind, that can lead to neuropathy. There can be exposures. Someone has chemotherapy. Chemo can cause, certain types of chemotherapy can cause damage to the nerves. Exposures to heavy metals. Exposures where we have to think about people who have served during wars. We have to think about exposures they may have had there. We have to think about exposures with insecticides. We have pesticides, things like that. So we go back into what people, one of the questions we always ask is, what do you do for a living? What do you do for a living? And that's really important to understand. So you really need to get to know the person as a person, the patient as a person. And then we keep looking. And, so there's those initial tests that we do, and then we keep going. We do more testing, vitamin E levels, vitamin B1 levels. It can get pretty fancy. We look for infections, hepatitis B, hepatitis C, HIV, syphilis, the list goes on and on. And so when you're getting a very specific workup for neuropathy, the workup can change depending on, is it the small fibers? Is it the large fibers? Is it the nerve? Is it the covering of the nerve? And so neuropathy, I think it's really important for everyone to understand how very complex it is. It is not something that is easy to understand. It doesn't always present in the same way. When you learn about it and when people think about it, it's easy to say, oh yeah, it affects the feet first and the hands first, and then it'll slowly climb up your hands and it'll slowly climb up your legs, and that's what happens. But that's not always true, because small fiber neuropathies can be patchy. They can be normal you can take samples and they'll be normal at the ankle, normal at the hip, and abnormal in the middle. Well, goodness, what do you do with that, right? Or it can be abnormal down at the ankle, normal up here, and it's actually the small fibers, not the large fibers. So it can be very, very complicated. And again, that's why I'm not sure I understand. Okay, my watch doesn't understand. But so right on cue, watch. I'm really bad at technology too. My patients know that I'm terrible with technology also. So, oh goodness. So at any rate, I think what I wanted to convey tonight was, not only is neuropathy is certainly not straightforward, it's complex. It is very individualized based on the patient. And when you find a provider and when you're working with someone to help you, you want to have someone that understands that you are a person, that there are certain things and certain ways you want to live your life. And it's our job to help you do that, not tell you can't because you have neuropathy. So when patients' neuropathies get really bad, driving doesn't go so well because they can't feel their pedals. So we give them hand controls. Because if I take away someone's license, I take away their independence in a lot of ways. And that's not very kind. So I bring it up early on to say, hey, this may come up someday. Maybe it'll be decades from now. Maybe it'll be in 5 years. Maybe it'll be in a year. I don't know, because everyone, again, progresses differently. But if you bring it up early and you're talking about it, people understand. One of the most common questions I get is this going to put me in a wheelchair? And most often, I like to say no. But I can never predict what's going to happen or how quickly something will get worse. But certain types of neuropathy, I can be more confident in saying no. In other types, I have to say, I don't know. But that's why we're going to work together. I'm going to see you every so often throughout the year. And I'm going to be able to tell by what you're telling me and by how you progress over time. We sort of, in our minds, plot, because I have exams from across a year. That's going to tell me how quickly is this progressing. We do things, and I'm going to bring this out. I knew I brought this stuff for a reason. So you all I know have seen these kinds of things when you're at the doctor. So good neurologist is always going to check your reflexes. They're always going to check vibration sensation. But again, this is for the large fibers, not the small ones. And then they're going to use one of these things. In your PCP's office, it'll look almost like a little brush, but the neurologists tend to use these little pins. And it's really important that when we examine people, each time you come in, we don't ignore it. We say, okay, we're here for a neuropathy checkup. I'm going to check and see where you can feel me at. I'm going to check and see how your reflexes look. Because as typical neuropathies, those large fiber ones, these axonal ones, as they progress up the leg, I want to know how quickly that's progressing. So I can judge that based on taking this and saying, tell me when you feel that it's sharp. And so if I've seen Karen a year ago and I'm comparing the exam to a year later, I'm going to know if it's worse or not. And I'm going to know how quickly it got there. Reflexes in large fiber neuropathies, as they progress, reflexes will go away. So if you have a neuropathy that affects your feet, you'll lose your reflexes at the ankles. And that tells me, okay, it's progressing. Then if you lose your reflexes at the knees, that's a bigger problem. Because again, as we become numb, we become tingly, as we can't feel things, as we experience that pain, we all do it at different rates and at different times throughout the course of the disease that you have. One of the other things I'll share briefly, and then I can open it up just to sort of open questions and talking. One of the other sort of concepts I like to share with all my neuropathy patients that I think is really important is the idea of how neuropathy can affect gait or walking. So as neuropathy becomes more severe, it causes, you're unable to tell where your feet are. So patients fall. Patients will come in and say, I'm having more falls, I'm unstable, and losing that stability, that equilibrium, we lose that as we age a little bit, so that plays into it. But it also, our nerves age, so that plays into it. But as we lose our nerves in our feet and up into our legs, it's much harder to tell where we are. So that's why I check vibration in people. That's why I'll say, close your eyes. I'm going to move your toe up or down. Tell me which way it's going. And if someone says to me, I have no idea, then we have a problem. And you have to make them close their eyes, or sometimes we cheat. So, and I do it too. So one of the things we have to realize is there will be a time when it can take that ability away. We won't know which way our toe is going. That's why doctors so often will say, check your feet, make sure they haven't been hurt. Because if you have a wound, you might not realize it. And that's just not in diabetics. That's in anybody with neuropathy. So I like to tell people, we stay, and this isn't written in a book anywhere or anything, but I like to think about it this way, and I think it's helpful, and you all can tell me, can give me feedback at the end if it's not. But what I like to say is we depend on different senses to keep ourselves upright and standing and walking straight and not falling down. We depend on our eyes. So our eyes, if we can see the horizon and we can see where we're going, we can walk straight and we don't fall down. How many of you have been on a boat, all of a sudden the horizon's going like this, and people are falling all around on the boat, and some people are throwing up over the side of the boat, right? Because they're getting sick. So sight plays a role in our ability to stay stable and upright, to keep our equilibrium. The second area that is really involved is hearing, is our ears. If any of you recall ever getting an ear infection where your ears get really stuffed up, suddenly you're dizzy all the time, right? The room sort of feels like it's spinning. So the ears play a role. We don't realize how much hearing is involved, but it helps a lot with our equilibrium, our ability to stay upright and not fall down. That whole vestibular system, the system that keeps us upright, our equilibrium, a fancy word to say equilibrium, our vestibular system, connects into our brainstem, so part of our brain. If you get a stroke in that part of your brain, it can affect your equilibrium. So that's all connected, ears to brain. Then I tell people, you also depend on your feet. So if I stand up, and I know you're not going to be able to see this perfect, but I'm going to stand up anyway. If you stand up, I'll like bend down a little bit. So if you stand up and I have my feet shoulder width apart and I close my eyes, I'm good. I'm not falling. And I know if I take a step forward, I'm going to hit the table. My eyes are closed though. See? And then I know if I go this way a little bit, because I can feel where my feet are, I'm going to touch the chair. And if I step this way, I'm going to touch this patient somewhere. There she is. But I do that all with my eyes closed because my hearing works and my feet work. My feet are able to tell my brain where I am in time and space. And so I can figure out where I need to go when. If all of a sudden my feet can't get that message to my brain appropriately, when I stand up, my feet aren't working, but my eyes and ears are. Suddenly I close my eyes and I'm like this, right? And people fall. So if you think about the most common place for people to fall is the shower. Why? Because one, they have neuropathy. They can't feel their feet. The signal is not getting from their feet to their brain to tell them where they are in time and space. I'm in the shower. I'm at this spot in the shower. I'm safe. I know the wall is here and the other wall is here. I'm good. But that's not working. Suddenly, there's water in your ears. So now your vestibular system is impaired and you're going to get dizzy. And then you close your eyes and tip your head back to wash your hair. What's going to happen? All three systems are out. People fall down and end up in the emergency room. So one of the biggest tips I give to people is when your feet aren't working and that signal is not getting to your brain, you need to start depending on everything else. You need to depend on your eyes. You need to look down and see where your feet are. And that's the only way you can prevent yourself from falling. So people often say, I can walk up steps fine, but I can't walk down them because you're not looking down to see where you're going. But when you're looking up, you are. And so that's why it's harder in patients with neuropathy to go down steps than it is to go up steps. Strength aside. But when you're feeling, because you're not looking. So you have to look down. Well, then that brings up a whole nother thing where you have to keep looking up too, because you have to make sure you're not running into a wall. So there's a lot that goes into that, but that's one of the biggest tips I pass on to people, because understanding how those different senses work together and how important it is, not just feeling in general, but that idea of what is called proprioception, the ability to tell where you are in time and space. That test your doctor does when they say, close your eyes. Am I moving your toe up or down? If you don't know, you could fall. And so we have to depend on some of those other systems. But that's just one of my tales, one of my helpful things that I like to share with people that I think is helpful. So again, you can all tell me if it ends up being helpful or not. Overall, that's sort of the key things I wanted to pass on to all of you was, one, I really, am passionate about this, and I want you each to find a provider that you can work with that gives you hope, because neuropathy can be scary sometimes. It is often misunderstood, and we have to recognize that it's a big deal, that it changes lives, and that we can do things for it. We can help. We need the opportunity to do that, but we want to. And sometimes it will take a few steps. Sometimes you will feel like you're taking a few steps backward before we find the right thing that will work for you. But remember, there's not any one thing that's going to work for everybody. So it's not that your doctor isn't thinking about you or isn't good at their job. It's that every single person experiences medications differently, experiences neuropathy differently. And understanding that is key to treating it, because you have to figure out so many different things about it. Is it the small fibers? Is it the large fibers? Is it the nerve, or is it the covering of the nerve? And what kinds of things are contributing? And I think one of the most important questions to ask, if any of you are diabetic, to ask your provider is, okay, I'm diabetic. That doesn't mean my neuropathy is all because I have diabetes. Have you checked my B12 lately? Because I like to look at it as multifactorial. Just because it's one thing doesn't mean something else isn't playing a role. So it's much more complex than just, you have neuropathy, 8% of the population over the age of 55 has neuropathy, see you in 6 months. It's much more complicated than that. And there's a lot of things we can do for it. Can we cure it? No. In neurology, people often say to me, why'd you go into neurology? You can't cure anything. There's neuropathy, there's Parkinson's, there's MS, there's ALS, and no, we can't cure it. But we don't have a cure for diabetes or high blood pressure either. And so you find what you're passionate about in medicine, and you do it. And I think I've been so lucky and really enjoyed my time so far practicing here in this area, because I feel like my patients have wonderfully been very receptive to talking to me. And that's so important. And it's so important to take the time to get to know each other. I like when my patients know something about me and something about my family. And I like to know something about my patients, because it keeps us invested in each other. And that's really important to have in your relationship with your provider, whether it's your general provider, your neurologist, your cardiologist, whoever it may be. I think I'm good. Now, I just want to open it up to just general questions about neuropathy, about treatment, about anything.
Do you give all your patients that you just see, do you give them a test for the B vitamins?
I do.
Right off the bat?
Mm-hmm.
Yeah.
I do. So that's in my initial sort of, and that was Bill talking. He asked that question on if I check B vitamins in everyone, and I do. Again, that's the idea that, okay, if someone's sent with me with severe diabetes, okay, but they could also be B12 deficient. If I supplement that, it might help their symptoms a little bit. Or someone might also have too much B6 in their diet, and that might be making things worse. So I do. I always check B12 and I always check B6. And then if it's been a number of years, like sometimes a patient will come to me, they've been seeing another doctor for 10 years, they've had neuropathy for 10 years, B6 and B12 were checked 7 or 10 years ago. But that doesn't mean they're not contributing now, that isn't something that has developed. So I often then recheck it.
Okay. Would you say a high percentage of your patients have a deficiency in Bs or too much?
Right. I would say a high percentage have very low B12. B12, so in every single lab system, there's certain things that are normal, certain ranges. So in general.
Okay. All right. I don't know. Can you hear me?
Yes.
All right,
Yes.
great. Thank you, Judd. We wanted to pause there because these are the question and answers that the Pittsburgh group generated. And of course, we don't have access to Dr. Eicher directly, so we can't ask her today our questions. But we have two thoughts on that. We might ask her if she would be willing to meet with our group live. And then we could ask our questions to her. But as I said in the chat, she has 2 young children, so a Saturday afternoon might be an imposition. So we thought at least by sharing this, we would have an opportunity to learn from her. And I can see from the chat that other people think she is terrific, wonderful, not too technical. So I think the takeaway for me was her focus on how individualized this disease is and how there is no single answer, that each of us are trying different options, different treatments, different supplements. And even though we can't ask her directly, we can listen to the questions after the break, or at least some of them, like the B12 that came up initially, and then stop and simply talk among ourselves about questions that she raised in our own minds or in our own experience. And we don't have her expertise, but we have the expertise of each other and the hope and support that we get from being able to talk among ourselves and listen, hear, and learn. So, Bill, I'm turning it back to you. I think we are going to the break now. I'm not sure on the agenda.
All right. We can-
Hey, Bill, is she gone? Because I'd love to have her
Well,
phone.
she will be back, but what we're gonna do is we're gonna take a quick 5-minute break. But my only and get out and stretch and get some food or something, but listening to her, I'm just sorry that I did not meet her 15 years ago, but
Right.
I think everyone would feel that. And as Brenda said, wish we could clone her and bring her to DC, because this is the kind of neurologist all of us want to have and are having trouble, I'm sorry to say, finding, at least I am. And so we're going to take that break, and in 5 minutes, after everyone's had a chance to stretch, etc., we will resume our discussion with a short briefing on the questions they asked in Pittsburgh, and then closing that out and having our own discussion. All right.
okay, let's take our break.
Thank you. Judd, how long do we have planned for questions now? I can't see the agenda.
I'll show you the agenda. Here it is.
Thank you. And can you move it to the right?
Yeah.
So we have,
All right, I'm
3:30
back. We had a open discussion for about 20 minutes, and we can certainly extend it another 10 easily.
yes. Okay, so we're going at basically, we're 5 minutes early, so we resume at 2:55 with the
2:55, and then I just want to say a few words about how we do part 2 and talk
Okay.
about seeing new people and so on. And
Okay. So we'll basically start the questions at 3, and they take longer than 30 minutes. They
Well,
are-
she's going to come back. She's going to come back and answer some more questions, correctly, for about 10 minutes, or?
Well, no, see, where you have part 2, that to me was her question and answers, correct?
Correct.
Okay,
Okay.
that's 38 minutes long if we're going to do the full recording. Or we can stop at about 30 minutes, or we don't even need to go that long.
I think we go for part 2 for about 10 minutes and then open it up.
Wow, that's only showing a few questions. Is that, you think that's the best use?
Uh,
She has 30 minutes of questions.
All right, and we've done what, about 5 minutes of them? 10 minutes?
No, you have part 2, a whole half hour.
Okay, but that includes new people. New people talking.
No, part 2 was only going to be question and answers, and then at 3:30 to 3:50 was the open discussion with new people.
Okay.
So we want to cut the half hour of questions with Eicher to allow more new people?
I think so, yeah.
All right, so Judd, you're gonna have to watch for where a logical spot to end the question and answers are.
Okay.
Do you want me to say a stopping point, or do you want to just go about 15 minutes and wherever there's a logical stopping point, stop there, and then Bill will talk about new people?
Yes, let's go about 15 minutes and stop.
Okay. I didn't think that, so I didn't stop. Debbie Bitts is much later. She's like 20 to 25 minutes into it.
What Debbie Bitts?
Okay, let's do it. When they come back. Hi, Susan Tipton.
Hi.
Oh, she's there cleaning up again like last month. That's
Throwing
funny.
evidence.
Very good.
So who is Debbie Bitts?
Oh, she was just one of the people in Pennsylvania who asked a question very specific about Charcot-Marie tooth. And I don't know if our members, if anyone has that illness. So I thought she might be a logical stopping point. We're trying to debate, Susan, whether it's more important to listen to Pittsburgh's questions or leave the open discussion, leave that and go to our open discussion.
Pat, this
I
is-
think you should provide this video to people and they could look at it at their leisure with the questions and also get the new people introduced here today.
Well, it's posted already on the website, and Judd is going to go
Okay.
over how you can find that later in the program.
Thank you.
I agree. I think that's a good option. People can listen later too.
Okay.
I'm looking forward to
So we're
seeing.
going to go about 15 minutes to see the interaction, the interplay between her and questions she got, and then we're going to open it to discussion. While we're sitting here, what do you think of this pre-recorded presentation? Knowing it's difficult to get. speakers.
Fabulous.
Yeah, she's so
Wonderful.
good. I mean, it's
She
just, yeah.
is terrific. Yeah, she's
Mhm.
absolutely terrific. I mean, I just got a new neurologist who is very good. I mean, I was very happy. So, you know, so
Who is
she was
speaking,
very
please?
kind. This is Karen.
Karen, last name?
Oh, Ryan, sorry, my video's not on, sorry.
Karen Ryan,
Yeah.
there, thank you. And where are you?
I'm in New York.
Okay. Well, congratulations on finding a neurologist that's going to work with you. I'm still looking.
So I
Yeah.
actually looked her up on Google and I found, where she works. The reviews for her, 4.9 out of 5. The comments are phenomenal. So, but it does make me think that the neurologist that I saw at Inova Health System, who is Dr. Choi, who finally gave me a good evaluation after over 20 years, said, that what we have is a subspecialty and that most neurologists don't know how to diagnose this and don't know how to treat it. And her presentation confirms that for me.
Yes.
Pat, could you possibly ask her if she knows anyone in this area who
We
subscribes
did.
to her philosophy?
We did at the end of the Pittsburgh meeting, but she didn't really have anyone that she could identify. Now, she was supposed to send the leader of the group, Bill Wilshire, a list of autonomic centers for people who have autonomic issues. But I never saw that, so we're going to have to go back to her and say those two questions.
Okay, Pat, we're going to start part 2, and we're going to, for the group, we are going to go about 15 more minutes. And she's going to be answering questions to a group in Pennsylvania. And then we're going to stop the video and then go to our group here and talk about, new people who just joined us and questions they may have concerning what she did, but as I said, I wish I'd met her 15 years ago. But anyway, Judd, if you would pick up on.
Number we use
part
is
two.
people say, okay,
Judd,
if
could
it's
you start it back at the
190,
very first question about the B vitamins? Just go a little bit back.
Okay. Somewhere. You can't see that.
B
but
vitamins,
I do.
right off the bat?
Mm-hmm.
Yeah.
I do. So that's in my initial sort of, and that was Bill talking. He asked that question on if I check B vitamins in everyone, and I do. Again, that's the idea that, okay, if someone's sent with me with severe diabetes, okay, but they could also be B12 deficient. And if I supplement that, it might help their symptoms a little bit. Or someone might also have too much B6 in their diet, and that might be making things worse. So I do. I always check B12 and I always check B6. And then if it's been a number of years, like sometimes a patient will come to me, they've been seeing another doctor for 10 years, they've had neuropathy for 10 years, B6 and B12 were checked 7 or 10 years ago. But that doesn't mean they're not contributing now, that isn't something that has developed. So I often then recheck it.
Okay. You say a high percentage of your patients have a deficiency in Bs or too much?
Right. I would say a high percentage have very low B12. B12, so in every single lab system, there's certain things that are considered normal, certain ranges. So in general, the number we use is people will say, okay, if it's less than 190, you're deficient in B12. In the neurology world, we say if it's less than 400. So it's going to come up as normal, but in actuality, we see that people can have pretty significant symptoms under 400. So we supplement if a number is under 400. And so it's very dependent again on the provider and how they were trained, because everybody gets trained a little bit differently. But I certainly supplement if years ago, it used to be less than 300. Now we say less than 400. So now I'll find some people that I used to do 300 for that I now have to supplement that I wasn't supplementing before. So it's important that we stay up on the recommendations because that does change over time. Since moving to back in Hershey, I found maybe 1 or 2 B6 toxicities where they were high levels. And why was that? Well, it could be something in the diet, or it could be that one of the multivitamins they were taking had extra B6 in it. It was a different vitamin. Well, now that I'm in Southwest PA, since I've been practicing here, I feel like maybe 1 in 15 has extra B6, which is a lot.
Yeah.
And so I find a few a month. And I have to say, okay, so I've really learned what foods are high in B6 because I've had to look it up multiple times. But we don't know the reason. There's hypotheses out there about what can lead to high B6, certain vitamins or supplements that people take is that causing that number to go up and then contribute to their neuropathy, but we're not sure.
I have a couple questions. First question, outstanding presentation.
Oh, thank you.
Yes.
Bedside manners, incredible. Really good. Many doctors come across as well as you've come
Thank you.
across here. And you do see patients, so if I take part and call, all right. And then just curious about any recommendations for supplements. I hear a lot about alpha-lipoic acid.
Sure.
Here he went and he talked about how alpha-lipoic acid, and I've taken it and I've had like virtually no success.
Improvement, okay.
And then diet. Is there anything that you suggest, recommend, stay away from? Anything you suggest go towards?
Okay, great questions. So first I would say in the realm of supplements, I'm all for it, but I ask that people tell me what they're taking, because sometimes in those supplements are added additional things, additives that can be dangerous for the nerves. And so I always want people to bring in their bottles for me so I can look at it with them to say what's good, what's not so good. No, I want to say, and I'm going to hedge here a little bit, there's nothing specific that I recommend to my patients. I use sort of an overarching concept, which is anything that's an antioxidant. So fish oil, vitamin E, vitamin C, anything that's an antioxidant is helpful to the nerves and to the nervous system. So I look at it as a whole because I want to treat the whole nervous system. So I say supplement wise, anything like that is going to be a plus. People will often bring into me some of these newer things that combine a whole bunch of stuff together. And they'll say, I got this. I'm like, that is great, but don't waste your money because you can buy all that stuff over the counter separately. Because they'll just take a bunch of antioxidants, mix them together and call it a special, whatever that is. And so I say just in general, antioxidants are really good. From the standpoint, what was your other question?
Diet.
Oh, that's right. Diet, not specifically, stay away from or avoid. I recommend a Mediterranean diet to most of my neurology patients. It keeps the brain healthy, it keeps the nerves healthy. So big thing is to eat a little more fish than you're going to eat red meat. Having red meat in your diet is important because we don't want to get anemic. So I never say don't eat red meat at all. You know, you want to have it in your diet, but you want to have it minimized. Chicken is the same way. Chicken's actually really high in B6, which we don't want too much of, but chicken is extremely healthy. So you have to be careful about that and how much you're doing it. So you don't want to eat chicken 5 days a week.
And we do.
So
We do. Try to stay with.
we need to check your B6.
Trying to stay with red meat, eating a lot.
And that's what happens, right? And we all try to do what we think might be best, but every single provider is going to tell you something different. And so if I can generalize it and say, lean toward a Mediterranean diet most of the time, but it's okay to do some red meat. It's okay to do nuts and things like that, that you still need those types of vitamins and those fats, fat and carbohydrates. It's okay. And my recommendations are obviously different when you have a diabetic patient, because then that has to change and the number of carbohydrates has to, all those things. So but in general, we stick with that. I also think one of the biggest things you can do more naturally is exercise. And so many of my neuropathy and myopathy muscle patients will say to me, what? I'm too sore. I can't. I spasm all the time. I'm numb. I said, that's my job. I have to fix your symptoms so that you can live your life. But the very best thing for the nerves is to remind them what they're supposed to be doing. So if I like this analogy too. If you take a brain and you put it in a dark room and you close the door, it's not getting any stimulation. It's not hearing any voices. It's not watching TV. It's not interacting or socializing with people. What's going to happen to that brain? It's going to shrivel up. Parts of that brain are not going to work anymore. You're going to go back in and it's going to look terrible. Same thing with the nerves. Suddenly we're not stimulating those nerves because it's too hard for us to walk or exercise. Then suddenly those nerves are going to say, I'm not needed anymore. What have I been doing all this work for? And they shrivel up more. And so that idea or that concept, I think, is very helpful. We want to consistently and persistently stimulate those nerves to do the job they were made to do.
One more quick
Yeah.
question. I just read this morning, because I ride a recumbent bike.
Oh, good.
30, 40 minutes.
That's great.
But I just read this morning, peripheral neuropathy, blah, blah, blah. Walking is like the most superior thing. The bike riding is nice, you're doing great for your heart. But walking is what will absolutely be the best exercise for the. So you're on board with that also?
Absolutely. It just is the way you're stimulating the nerves to move. But the fact that you're doing any level of exercise is going to be helpful to those nerves.
Okay.
So if you're enjoying the bike, it doesn't mean give the bike up.
Okay.
Add a little bit of walking, I think that's great, but it doesn't have to just be walking.
Okay.
You know, there's a lot of theories out there, and next year it may be, oh, we've discovered that if you jog, well, I'm going to tell you right now, I'm not jogging anywhere. So I don't care how much somebody tells me to do that. I've never done it. So I jog when I have to run after my children when they're doing something they shouldn't, but otherwise, that's not me. And so you have to, again, think about the individual. So you enjoy the bike, that's great. Maybe if you could walk once a week. I don't know if you belong together or not. I guess okay. If you, maybe once a week you decide to do that together now that the weather's hopefully changing for the better.
We take our dogs for walks.
That's perfect. That's perfect. And then doing the recumbent bike in addition to that is great.
Bill, Diane Mowitz has her hand up.
You want to know about the B12.
How do I, is she on here?
Yes.
Yeah.
I have a question. My question is, I have peripheral neuropathy. Well, I also have erythral myalgia too. But
You also have, I'm sorry, say the second part.
I have peripheral neuropathy, but I also have erythral myalgia too.
Okay.
And what's
Okay.
But my peripheral neuropathy, I've had it probably 4 or 5 years, and fortunately, I do not have any pain, at least not yet. I don't have numbness and I don't have tingling, but I have the most constant annoying feelings in my feet all the time. I just hate having my foot on the floor, whether it's sitting, whether it's standing, whether it's walking. And I'm looking into considering one of the newer high frequency 10 kilohertz spinal cord stimulators. Is that something that I maybe should look at and consider that might be helpful to all this paresthesias or annoying feelings for my neuropathy? Is that worth looking into, or?
So I don't want to say that it's not helpful, but I have to say that those patients that I've had that have done it have not found it as helpful as they hoped. That doesn't mean there's not a role or a place for it with the right patient, but I have not seen it be as successful as you'd want it to be when you go through such a significant surgery. And so I recommend patients that before they do it, they make sure they've exhausted all other options with various topicals, some of the alternative treatments for medicine, which are certainly an option for some people, as well as some more of the oral medications. Again, both of your conditions make treatment for you much more difficult or more complicated, but there are certainly certain things that we'd want to make sure had been exhausted before you went ahead with a surgery like that. However, I do think it has its role. I just haven't seen it personally be as successful as I know my patients would like or I would like, but that's my experience. Someone else's might be very different.
Are you familiar? Are the newer high frequency spinal cord stimulators that have been out the last maybe 4 years? Is there a chance that they could like damage your nerve to that? I mean, is that a?
So there's always a chance locally where they place the stimulator that there can be damage. I've had some patients have those types of side effects. Not necessarily damage to the nerve already damaged from the neuropathy. So not looking at it that way, but looking at it as, oh, it has led to a new problem with pain, but for different reasons. So my experience with it is minimal, but when I've seen it, it hasn't been as successful, like I said, as I would like.
Okay.
Doesn't mean that there aren't neurologists out there that maybe seen it used more in different ways where it has worked. I just haven't seen it.
Well, thank you. You are just great. I wish we had muscular neurologists like you all over, like right here.
Thank you.
You are just fantastic.
I appreciate that.
Yes, you're great. Bill would like to know, how do we know if he has neuropathy? He was diagnosed by a doctor, and how do you really know?
So there's a number of ways you can know. So some of the symptoms that Bill might share with his doctor would certainly be an indication. So numbness, tingling, burning pain, zapping pain, things like that. If there's no symptoms, but somebody's falling, sometimes we find that people have neuropathy. So sometimes it's due to gait changes, instability with walking. Sometimes people will come in and just say, I am off balance, and nobody can figure out why I'm off balance.
That's what Bill had. His symptom was he couldn't get his balance. He'd stand up and that was his first symptom, wasn't it, Bill? You couldn't get your balance.
Yeah.
And that is when he went to his chiropractor, and the chiropractor checked him and said, well, Bill, you need a neurologist.
Yeah.
And he sent him to a neurologist, and the neurologist tested him.
Yep.
And he did tell Bill he had
neuropathy, but he absolutely did not say there was anything to do for it. And he said Bill was doing, that was like about 4 or 5 years ago.
Okay.
We really do, things are a little different. I mean, he's going to a chiropractor now who's putting lights on his legs.
Okay.
And
Are they effective?
Some people like some people feel better after getting those treatments. So I tell people it's okay to use. There's no clinical trials that say they work. Does that help? So there's no data that we cling to in our neurology world that says, okay, this is going to be a great option.
well, what's the treatment for neuropathy? Bill wants to know.
No problem. So I'm gonna go back to his first question, which was, how do we know he has it? So it's not just his symptoms of being off balance, but it would also be all of these things that someone tested to prove it, plus either an EMG nerve conduction study, the zapping and the poking.
Right.
And if that's normal, then the skin biopsy. So you need to go in that order. And then there's this whole other realm, which I didn't mention yet, but it's called autonomic neuropathy. And sometimes that goes along with small fiber, but also can just present as what's called dysautonomia. Your heart races, you pass out. There's a whole different, you have urinary trouble. It's a whole different realm of neuropathy.
There's a guy here that had diarrhea constantly.
Correct.
Quit his job because of that.
Yes, and that's a dysautonomia or autonomic symptom. So skin, yeah, you can get a nerve biopsy. That's done when they're trying to figure out, is it the nerve or is it the covering? So they'll do biopsies for that.
Okay.
But a skin biopsy is for small fiber versus large fiber. So they'll do all of that to figure out if someone has neuropathy. And then the treatment for neuropathy are the things I said. So you'll do all that testing to figure out what caused it. If we can find a cause, we treat it. And we try to make it better. We're not going to cure it, but we try to slow it down or help it feel a little bit better. Then we use things like that sheet I gave you of topical ointments and medications that can help with the symptoms. And physical therapy is really important because that's a big part of learning how to walk without being able to tell where you are in time and space, right? That's working on that one element of how you walk more stable.
Well, Bill, he did say, he wanted me to ask you, what exercise is good for Bill's peripheral neuropathy? Would it be daily walking or gym?
Daily walking.
Okay, you can walk daily, Bill.
Well, I had that light therapy and it helped me.
Yeah.
Okay,
So
that's very good then.
different people, different results, and that's great.
We don't really know what happened when he first had his first things done. You know, like you were talking about.
Mm-hmm.
Because the doctor never really checked him. He didn't want to check him again. He said everything is, there's nothing to do for it, you know.
Right, so I think that's where one of the misconceptions is, and that's what I wanted to talk about, that there is really a lot we can do, and a lot of different things we can understand, and a lot of ways we can try to help. And it's important to know if he's had it this long, how much has it progressed? What does it look like now? How can it affect his
That would
life?
be very interesting to
Right.
know, but I guess we could get an old record from the doctor.
Yep.
That has a
And then
doctor.
we
He could
work
send
together
some
in that.
papers, because he, I'm sure, has everything.
Did you have a question?
Yes, I have a question. It's actually a follow-up.
No, she's not.
Okay, two people are talking, sorry.
No, you're okay.
Couple more questions.
Go ahead, Pat.
Yeah, when it's.
Go ahead.
It's sort of a follow-up to your autonomic neuropathy comment. My sister has been diagnosed with peripheral neuropathy, diabetic peripheral neuropathy for several years. Recently, for the last 6 months, she has struggled with gastric issues, serious pain and constipation. They've done the colonoscopy and even looked at an MRI of her large bowel. They've looked at everything and said everything is fine, all the organs are normal, but she has constant pain, and they've decided that it's autonomic neuropathy as opposed to peripheral. Is there anything that one can do? I mean, is she destined to just use Miralax for the rest of her life?
So sometimes that does become part of daily life for people. There's more and more research being done in this area. So autonomic neuropathy is a fairly new thing, a fairly new concept, and we learn more and more about it all the time. And so over the last 5 years, there have been various dysautonomia or autonomic centers that have popped up. And so reaching out to a specialist there would be helpful to her. It sounds like maybe she's close to one already. I don't know. But that can be a very big source of information because they have a lot of trials going on right now for different opportunities for treatments.
How
So
does
yes,
one find someone? I mean, it's hard enough to find a neurologist who knows what you have so beautifully presented tonight. I wish you would move to Washington, D.C.
But, well, what I can do is I have a list of them. I can certainly send them to Mr. Wilshire and he can share them with you.
Excellent.
And that would get yeah, absolutely. That would get your sister started. Did you mention that she also has diabetes too?
Yes.
And dysautonomia, that autonomic dysfunction, is a very large part of diabetes. Because when we think about diabetes, it's an autoimmune disorder. So she has a lot of dysfunction in her own body. And so fighting that and treating that can be so much more complicated. And again, very individualized. So I'm sure there's certain things they've tried, but there are other medicines that have both GI, it can give us good GI results, but also treat neuropathy. And those would be something to discuss with her doctor. But I can certainly recommend some names. Is she in the DC area?
Yes.
Okay, perfect. I'll get names to Mr. Wilshire of where the autonomic centers are, but I'll also focus on that area and give you a couple names.
Excellent. Thank you so much.
Okay, thanks. Yes.
Does hip knee replacements have anything to do with neuropathy or?
So I don't want to say they don't have anything to do with it. I think you have to consider if someone has significant neuropathy before they undergo a knee surgery or a hip surgery, because you have to prepare them for how it's going to change things or how it might affect recovery. Mm-hmm. Certainly doesn't mean you shouldn't have them replaced. It just means it can play a role. We often also will get people that sent to us that will say, and this happened a lot more when I was at Hershey, which was an academic center, so we got a lot more of the more difficult questions where we couldn't get answers for patients, much like your sister went through. Mm-hmm. So what will happen is, and I just totally lost my train of thought. It just went right out of my head. Yeah, thank you. Okay, so when patients get referred to us, they'll say, suddenly, I know, it's been a long day. Yes. Suddenly, I worked all day, then I went home and cooked dinner for the 3-year-old and 5-year-old husband. So like you get, so hip and knee, got it. So people will come and say, you know, I've had neuropathy for 5 years. Suddenly my hips are really weak. It must be my neuropathy. Well, what happens a lot of times with hip and knee weakness, hip and knee problems, is you'll get weakness in your leg. And it's not progression of neuropathy at all. It's that your hip flexors, your quads, can actually get weak because of difficulty with a hip or a knee. So the arthritis plays a large role in that. So the neuropathy can actually feel significantly better once someone has dealt with the arthritic discomfort in the knee or the hip, because suddenly the top of the leg is working much better. It's a great question.
Well, I just had hip replacement, and I think my neuropathy is a little worse than it was before that.
And that can happen too, because what happens with anesthesia is we tell people any neurologic conditions, anesthesia can make it worse. So surgeries can make it worse. When we have Parkinson's patients or dementia patients, ALS patients, we'll say, yes, you need the hip replacement, but I don't know how it's going to affect your disease overall. Just like sometimes we don't know what sets off neuropathy or what sets off ALS or what sets off, like, why did I get Parkinson's now? It happened right after I went swimming in that Florida beach or whatever they're relating it to, or right after I had neck surgery, I got Parkinson's. So we often think about neurologic diseases and think to ourselves, among us as neurologists, is there something in our DNA, our genetics, that make us prone to these diseases, and then something in the environment we encounter that sort of sets it off or makes it more prevalent? Yeah. So I think in a lot of ways it's similar to that. So I'm not surprised that you say that. I've heard that many times before. And it's not directly the medicine that does it. It's really the trauma to the whole body when you go through a surgery.
Right. Yes.
Go ahead.
Yes, doctor, yeah, I'm Debbie.
Hi, Debbie.
Hi, you were so informative. I just want you to know that, I've had neuropathy. I was diagnosed, just over 20 years ago. And, in Jersey, I don't know if you're in Jersey, you're familiar with, Morristown Memorial Hospital?
Okay.
And the group of doctors that I saw there, they had done EMGs. And at that point, this was like early on, I couldn't feel anything from my toes all the way up to my thigh. And my arms too, both upper extremities and my two lower extremities. And they sent me to New York. I went to Columbia Presbyterian. And I saw a doctor there who was he was actually retired. He was from Maine. He was the head of the neuromuscular diseases. And I had genetic testing done because they wanted to pull out Charcot-Marie-Tooth. Okay, so here I am now. 20 years later. Oh, and I also have Ehlers-Danlos syndrome. And I want to know, is there a link between Ehlers-Danlos and neuropathy?
There is. And so a lot of people have the conditions concurrently, and then dysautonomia plays into that world a lot too. So there are certain genetic studies that we do and things that we look for in patients that have both neuropathic symptoms and have Ehlers-Danlos. But when you have that, there is a more, I don't want to say an increased risk, but there's certainly a connection between the two because we often see them together. Sure. Have you lost the muscles in your hands?
Oh yeah, I can see if you look at my arms.
I know, I can see already. That's when you were talking and the certain way that you move your hands when you touch your hair, I can tell that there are certain muscles that would be missing. So I recognize, I mean, it was great that they checked you for CMT because that's often something we see. Charcot-Marie-Tooth is a genetic disorder that people inherit that leads to neuropathy and significant neuropathies. They can be axonal or demyelinating, so the axon or the myelin, most often the myelin, but there are tens and tens of different types of CMT. Also something that can look like what you have or how you manifested your neuropathy. That's one of those severe, significant ones I was talking about where it's the myelin more often affected, those demyelinating diseases.
I'm very advanced. Like I know, I've been to many doctors and
Do they call you, did they diagnose you with CIDP?
With what, the Charcot-Marie-Tooth?
No, CMT, did they find that you were positive for CMT? Or did they diagnose you with CIDP?
What's CIDP?
Chronic inflammatory demyelinating polyradiculoneuropathy, but
I've never heard that before.
that's what your muscles look like. So ask someone if you have that. But did they give you a diagnosis for your neuropathy or say what kind it was?
You know, I've had different things. Sensory motor neuron disease, does that sound familiar?
Sensory motor polyneuropathy is certainly a type of neuropathy, but my guess is you have the kind that attacks this part of your nerve, which, like you said, can be more aggressive and lead to that muscle change.
What is that called again?
CIDP.
CIPP?
D as in dog.
C is in Charlie, I, D is in dog, P is in Paul.
Okay.
Yeah.
CIDP.
It's in the chat.
Okay, it's neuropathy. Okay. You know, also, can I ask you another question real quick? your ulnar nerve. Does that have anything to do with neuropathy?
Well, it can be affected in any type of neuropathy. So you can get a focal neuropathy where you just have your ulnar nerve affected, or the nerve at your wrist, and that's called carpal tunnel. So you can have a focal neuropathy that just affects one nerve. You can have a polyneuropathy that affects many, and that can also include the ulnar. You can have something called mononeuritis multiplex, which affects various nerves in different arms and legs and places. You can have, so there are many, many different types. Diabetes can just cause ischemia or death of one nerve, one place, and it's from diabetes. So there's lots of different things.
Okay, because I've been to neurologists in the past, but the neurologist that I went to is the head of Lehigh Valley Hospital. It's LVH. I'm out in the Lehigh Valley in Pennsylvania.
Okay, I studied at Hershey, so right there.
Yeah, okay. It was, Dr. Mackin, his name was Glenn Mackin. He had passed away maybe 4 or 5 years ago. And I saw another neurologist, but to be honest with you, I don't follow up appointments, reminders or anything. And I live with chronic pain. I live with it. And you were talking before about guiding. That's something that has just entered my life now. I'm at the point now where, my 2 kids, they don't even want me getting in a car anymore.
Sure.
And it's really scary because what
Absolutely.
happens here is my left foot, I have to constantly be thinking, my brain constantly be thinking, you got to keep that foot all the way to the left because I actually got it stuck under the brake pedal a few times.
How scary is that? Exactly.
Okay, that's it.
Okay. Judd, I think you have ended. Thank you. We'll go back to the agenda. Yes?
Yes, let's continue. First off, I'd like to thank everybody for attending, and we will do our best to get Mary Eicher back again some way. But right now, I want to introduce or have the new people who have attended tell us who they are, where they live, what type of PE they have, and how do they hear about us. And you can raise your hand there's a raise your hand in the reaction comments at the bottom, or you can raise your hand like this and we will call on you. So is there anyone new who would like to speak up? Do we see anybody?
I do not.
Have I scared people away? Okay, I see Roberts, M.W. Roberts. Go ahead.
Activity solution. It's the largest, fastest, reliable method. Advanced speed Wi-Fi and cyber threat protection. Get started for just $49 a month. Plus, you can save up to 60% a year with that business model.
Judd, are you still on?
Prepaid card. Complete connectivity. One solution for wherever business takes you.
Wait a minute.
Business powering possibilities.
Judd, are you still on YouTube?
No. Oh, am I? Is that me?
I think Roberts is.
1 second, guys, till we get the tech part right.
No, where am I?
Okay.
I don't think that was me, but let me kill the page anyway.
All right.
Wasn't him.
Okay, then we can go back to M.W. Roberts and then Sunday Sly. If you'd like to tell us your name, M.W. Roberts.
You scared him away.
Going once.
Does he know how to unmute? Has he tried to unmute?
He has, she. We'll go on to Sunday Sly and we'll come back to M.W. Roberts. Sunday Sly, if you'll tell us your name and unmute.
Hi there. Can you hear me okay?
Yes, go ahead.
Oh, okay. Yep, my name's Sunday Sly. I have been trying, I'm from Corning, New York. I can't remember what all you wanted to know. I've been trying to find an answer for my neuropathy. I started having, actually my right calf of my leg went numb first. That was at the beginning of 2020. Shortly after that, a few months later, my right arm from my elbow to my wrist on the underside went numb. My doctor decided to start, sending me for some testing. She tested for MS first, did, blood work, the MRIs, I've been, oh my goodness, and they haven't found anything really. I've been everywhere that I can think of. I haven't found a neurologist that really did any testing like Dr. Eicher was describing. Actually, it'll be a year ago next Saturday, another week. I've been out that long when my feet went numb and I started having this incredible burning and stabbing pain. Since then, it's progressed up. It's in both of my feet now and up my ankle. And I walk with a cane. Still searching for answers. I have my next appointment is not until June in Rochester with a neuromuscular specialist there for actually a second opinion from a neurologist down here. So, hoping I can find something there. My experience has been with my neurologist. She'll tell me that they tell me I need to see a rheumatologist. So I see the rheumatologist and he tells me I need to see a neurologist. So I just feel like I have a runaround all the time. So, and then I found this group. I was searching. I had gone all the way down to Maryland to Hopkins. And he told me there was nothing I could do. This was my new normal and learn to live with it. So I started looking for support groups and information and what I can do to learn to live with it. And I found there's not a whole lot of information out there about peripheral neuropathy, but I was happy to find a couple support groups here on Facebook, and I really appreciate all the information I've got today. It's been incredible, and I thank you for accepting me here and having me, so I can meet all you folks and learn some more information.
Cindy, I appreciate everything you're saying, and I think many of the people in this group have been or are going through what you're going through. And I see a hand up. Mike, go ahead. Foxworth.
I just wanted to know what things the doctors did tell you to do. Did they tell you to exercise? Did they emphasize exercise?
They haven't told me anything. I have not got any answers. Nothing.
Well, okay.
Just frustrated.
Let me tell you the bottom line of what we seem to see as a theme, which is, first off, if you have the way you started with the symptoms only on one side is rather unusual, but if it's become both sides and both feet are involved, that sounds like it's typical. It's progressed to typical patterns, which may not be, but it sounds like it might. If it is typical, the doctors have started recommending people get exercise. Really try to keep these muscles working as much as possible. That's the only thing we know of that seems to be consistent recommendation. And secondly, if you're experiencing pain enough that it's really interfering with your life, you really need to treat it aggressively. Your brain can change if chronic pain goes on long enough. And those changes can make it very, very difficult to continue to deal with the pain. Again, we're talking here in the absence of real certainty about what's going on with you. But we do know that chronic pain can be a problem in and of itself. And so you need to aggressively do stuff to try to bring the pain under control. Because the brain will change. The brain is plastic and it will change and it will come to expect pain. If you can bring the pain under control, then your brain will recognize that these symptoms you're seeing, these feelings you're seeing are not an imminent disaster. It's not something that's catastrophe is right around the corner. And you can just kind of relax and the pain can become just part of the background of your life. So don't, be as upfront and try to get somebody to deal with the pain, even if it involves, what sounds like really aggressive treatment. Treat the pain and try to get your life back. If it's really been disturbed, get your life back so you're functioning again. That's really important.
All right, Mike, I appreciate your comments. Pat, you just
I just like to interject. This came up during the break. This video with Dr. Eicher is available on the website. And at the end of this meeting, during the wrap up, Judd is going to take us to the website and show you where you find the calendar for upcoming events and also how you can find past meetings that have been recorded. And you can look at these at your leisure. And then, of course, the Foundation for Peripheral Neuropathy also has videos that Sunday might want to look at. And Lou, if you put the Foundation's website on chat, that would help. And now back to M.W. Roberts, who has his hand or her hand up still.
Mr. Roberts, are you there? Going once, going twice. Gone. Okay, is there anybody else in the group who is new?
Bill, I just want to say, it looked a couple of times like M.W. Roberts. It's almost like when he's ready to speak, he mutes, or it's backwards. There's something going on there, but
He's muted.
M.W. Roberts, you are muted.
We can't
unmute.
We can't unmute. We can only ask him to.
And he pressed down the space bar and keep his
There
finger
you
on
go.
It's open.
All right.
Now it's open.
Mr. or Mrs. Roberts, go ahead. Going once. Going twice. Gone.
Okay, Brenda Siegel has a question in the chat about neurologist recommendations. Brenda, do you want to ask the group?
I think several people reminded me that I can go to the websites. As we know, a lot of these problems are genetic and we never knew about them, perhaps sometimes because people in our family didn't live long enough for us to understand what was really going on. But one of my daughters has rheumatoid arthritis, Sjogren's syndrome, Raynaud's syndrome, a multitude of autoimmune disorders, and now she's having difficulties with her feet as well. She's an ardent exerciser. She looks 20 years younger than her age. She's in fantastic physical condition, except that she's in pain. So she lives in Great Falls, and so I got Mike lives in Reston, so he gave me a name of a person there. And is it Rodney? I think there was somebody that you really liked. I think the last name might be Chou, C-H-O-U, perhaps, was it? I remember someone saying once that they had found a neurologist, Gordon, it's Gordon.
Sorry,
You
I'm
really
sleeping
found
on-
someone that knew peripheral neuropathy?
Yeah, I'm sleeping on the job here. So Dr. Chow was with Kaiser. He left back in October, and he is now working for Innova. I think he's got He works out of Fair Oaks Hospital because he can't work at Fairfax Hospital because of some regulation when he left Georgetown. I think you have to wait a certain amount of time, but he is with Innova, and he did tell me he was going to be developing a subspecialty for the conditions that we're dealing with. So it's Chow. I don't remember his first name, but I think you could probably, he said you could find him, on the internet. Check out, the guy was terrific. He's a neurosurgeon. He did all the studies in New York. Very, just like the speaker we had today, really an amazing, did all the evaluation that she's described and everything. And he's great.
Gordon,
He's
will you
great.
spell his last name, please?
I think it's CHOI.
Okay.
Okay, thank you, Gordon, and thank you, Brenda.
Thank you.
Walt Carlson, has your hand up?
Yes. Yeah, I just wanted to comment on Pat's question about the video format that we're using today. I think it's good. I think it's a good idea. What would make it better if at the end of the video, the doctor could have come on to answer some questions, okay, that came up. But I'm also glad to see that you're gonna post a video to the website, and indefinitely, because she's worth putting on your website and referring people to her. But you also might want to take the questions and break them up into smaller videos and have a list of questions, a page for the video, the first part, and then a page for the questions video with a separate link for every question. Okay, and then maybe ask her if she would agree to taking questions offline occasionally and making videos that the group could post to this webpage of her answers. Okay, that might make the video even more powerful. But anyway, great idea. Thanks.
That's a nice segue. That's a nice segue because part of our issue is Judd and Mike are swamped, and we have very few offers for volunteer help with the technical aspects. If you have that ability and are interested, we would love to have someone working with us to create video clips like you're suggesting, maybe one on Charcot-Marie Tooth or whatever. So if you have that ability, please tell us, let us know that you are willing to work with us. And again, as I said, we will be contacting Dr. Eicher, but we didn't want to impose on her having already done it once. We thought at least we can show the recorded presentation. Okay, Edward, has his hand up? Edward Lees?
Edward?
No.
Let's see.
No. Okay.
Here he is.
Minute.
Yeah.
Okay,
He says
yeah,
no.
oh, yeah. Yes, it's Mary Jo. I don't know why I can't get that first name in there. Anyway, what happened? I wanted to respond to Sunday Sly. First of all, I would maybe advise her to find a neurologist who would do an EMG and an NCS to possibly find out what type of neuropathy she has. And I don't think she's examined what type of medication might help her with her pain. The topical, or maybe gabapentin or Lyrica or something like that. I feel like we, as a group, maybe we can advise her a little more on some things she might be able to do. Sounds like she's just been left out in the cold with so far with her, what she has tried to find out about her condition.
Mary Jo, thank you for your comments. I agree with you about, again, I'll say many of us have been left out in the cold. And we've been searching, and we will do our best to help her out. Is there anyone else with a comment about today's program?
Yeah, I have a question.
Rory
Gordon?
has his hand up.
Gordon, go ahead.
Yeah, so she mentioned,
Hi, good to see everybody.
she mentioned a list, I thought, was it a list of medications that she carries with her? Do we have a copy of that?
Do we?
Yes,
Yeah.
It
it's
will
on the
be,
website.
it's posted on the website.
Great, terrific, thank you.
Rory, you have
Okay,
your hand up.
Rory, go ahead.
Yes, hey, good to see everybody. Most of you know that I live in Northern Virginia, and I've been diagnosed with CIDP for about 2 years now, which is a rare autoimmune condition that impacts the peripheral nervous system, as well as your muscles. But I wanted to say that I started out with just getting a flurry of tests, right? Some of the tests that the doctor mentioned, like the B6, the B12, thyroid, they went through the whole list to try to rule out what they would consider kind of like normal things, right, that you would look at first. And when all of those came back as, being negative, then they started thinking, okay, there's something else that is not so obvious. So we need to start looking in that direction. But one of the tests that I had was a nerve conduction test, right, that the doctor was talking about, where they put the needle in and they do the electrodes.
Right.
So that showed that I had demyelination in my arms. And at the time, they would only do your arms first, and then they would do your legs. So the first time I had just my arms done, and the doctor said that I had carpal tunnel. But the arm in which he said I had carpal tunnel wasn't the arm that was hurting. So like none of that made sense to me. So I wasn't happy with that response. And so I said, look, we have to find out what's going on. There's something else. But by that time, it had moved from my hands down into my feet. And it was on both sides, symmetrical on both sides. And I was getting burning, itching, stinging. And then it eventually went to my legs. It was difficult for me to move my diaphragm up and down to breathe. And then my scalp was like always on fire. I mean, it was just a miserable existence for a very long time. And I didn't have balance, so I would have to hold on to the wall, like in the shower and things like that. But eventually, I found a neurologist who, he has a large practice with MS patients and other conditions like that. So he started doing some testing. I had a lumbar puncture done, as well as some other lab work. And it turned out that with CIDP, you have a very small elevation in the protein that really should not be there. This happens to cross the blood-brain barrier. And so that was the telltale sign that one, it was autoimmune, but then there are certain conditions where you can tell what kind of condition that might be because of the level. And it ended up being a CIDP. But I will tell you this, as the conditions, progresses, you start to get other symptoms, and you don't know if that's because of your current one or if there's something else going on. So normally people don't have any autonomic symptoms associated with CIDP, but I was having them. And I couldn't control, like when I couldn't go to the restroom, which, was unusual. So, I mean, it took a while to sort all that stuff out. But in the meantime, they were giving me, medications just to treat the symptoms. But long story short, now recently I was diagnosed with Sjogren's. Well, that had been in the background this whole time. I had no idea. So it was doing all this stuff that, we couldn't figure out, what was going on exactly, So for me, I think with Sjogren's, it really impacts like 9 out of 10 women, and one of those 10 are men. And so that was something that was completely not on their radar, right? I didn't fit that picture. And then when they were doing the testing, it came out positive and nobody would believe it. So they kept doing the testing all over again. They wouldn't believe it. It came back positive again, and the number kept going up. So eventually they did a lip biopsy. They put me through all of that, only to prove that, I actually do have Sjogren's. But by now, that has impacted my organs. So, like my liver, now my pancreas, you name it, it's happening. But the thing with it is that for women, normally with Sjogren's, it's You know, it normally impacts like their eyes, like dry mouth, that kind of thing. But for men, for some reason, and they don't know exactly why, but men, it typically goes beyond that, and it impacts your organs, along with like joint pain. So I'm saying all of that to say, you know your body, and if a doctor is not giving you answers that you know you deserve, or if they're saying something that just does not seem right, you really have to press them, because I mean, it's your life. You deserve to live pain-free as much as you can, and you just have to keep on fighting. I know it's difficult, and sometimes you just want to throw your hands up. But I'm not a person like that. So I'll just keep going until I get the answers. But once you get one of these autoimmune conditions, they really just don't like to live alone. They love company. And so they would normally will bring, you know, a sister or brother along with them. So
Roy,
anyway, I just wanted to share that.
Roy, I appreciate you sharing. Very good comments. We're going to have to wrap up, but I'm going to also remind people that I know that Glenn has his hand up, but we have to wrap up. But again, at 4 o'clock, we're going to have overtime. So if you can stay around to ask questions, that's going to be great. But right now, we're going to wrap up, and Pat and Judd are going to show their wears and tears. Okay, go ahead.
We've had
Pat.
several questions from people about saving the chat. If you are interested, if you go to the chat, open it. At the very bottom, there's a series of icons, and after the smiley face, if you're following with me, there are 3 dots, the ellipses there, and if you click on that, the first thing that comes up is save chat. So if you click on that, you will save the chat from today's to your computer, and it'll disappear in a folder, and you can see it says .txt. You can rename it for today's meeting. You can put Dr. Eicher, you can put the date, whatever will help you find it again. So if you're interested, please do that, save the chat. All those little informational things from Glenn and Mike are there, and you can go back to them. Now, I think we're going to take a few minutes and go back to the website if Judd is ready. Karen, I'm sorry, we aren't going to get to you in this session, but as Bill pointed out, after 4 o'clock, which is the official end of the meeting, we have what's called overtime. Anybody can stay on as long as you want, talk to each other on a personal level, ask more questions. Go ahead, Judd.
Okay, we
going to show the calendar and how you can find upcoming agenda, upcoming webinars and other support groups. And
I want to find that list that doctor put up there.
Me
The
too.
list with the
Okay.
medications and the whatever. That's what I'm looking for. That's all.
Yes. So that's under calendar.
I'm having a little trouble here. 1 second.
The calendar, while we're waiting, lists upcoming events, but it also does past meetings. And when you go to the past meetings, if we recorded it and had permission, here he is, you can access, like Dr. Eicher's, one person, only one doctor did not allow us to record. So we have plenty of resources. And also Glenn has indicated that the Western Neuropathy Association also has videos you might want to consult. Go ahead, Judd.
This is our website, and it's pretty easy to get to. Right here, the third item on the top menu is calendar. You click on the calendar, and up comes this page, which shows you all the upcoming events. Now, this will disappear in just a few minutes when it gets to be closing time. And then we start in with other events. We have a once-a-month meeting, but we're also listing other meetings as well. Like WNA is an incredible a collection of helpful events, both live and recorded webinars. So That's a really good place to go. This is just one of them right here, a virtually support group that happens in California and Texas and so on. The Pittsburgh area neuropathy support group meets later this month on a Wednesday, third Thursday and Wednesday. The day after the third Thursday in February, the Bethesda Chevy Chase group meets. And then FPN, the Foundation for Peripheral Neuropathy, is sponsoring a webinar with Dr. Latoff. If you've been diagnosed for a little while, you probably know who he is. He's an author and researcher, and that's on February 22. All of these events are no cost to you. You just have to sign up for them so you can get the link. Okay, that's that. Let me go back to the homepage and show you how to get access to this material. This is our homepage again, and you can go here under events where you go to past meetings. Past meetings are a list of everything that we put on the web for the last 5 years. And the Dr. Eicher spoke in April. That was the original. And right here on this link, April, that's the key to remember, April of last year, you can go here and see the video we just saw, which is on YouTube. It's on our YouTube channel. Or you can go here to get the thing that the woman just asked about, causes of neuropathy.
The handout.
What's that?
The handout.
The handout. And then Gordon asked about medications, I think. These look like they've been, photocopied about 40 times. But anyway, we got that from, Dr. Eicher, and we could, we probably should retype this. But anyway, we just took it and put it up on the web as is. You can still read that, and this is to me an incredible list of available medications for the web. So that's it for me.
Could you show her causes of neuropathy there under Dr. Eicher?
Yeah, this is another piece. It's even worse shape, but you can still read it. It is what Dr. Eicher gave us. And I think this is an incredible piece, especially if you're interested in medicine. It talks about epidemiology and history and how they diagnose. Watch this. You go on down the page to where look at all these things that can cause neuropathy. And then you go on down the page, and there's other things. I'm not going to take time with that, but watch this. This is how doctors diagnose neuropathy, and it's right there. So there's a lot of information on this little sheet. I'm not saying it's going to make you a physician, but it gives you a lot of insight into what's going on. One of the things I learned from Dr. Eicher was just how hard it is to, diagnose this condition. I got a new respect for neurologists, I guess. So that's it for me.
Okay. I also had put together a list of all the support groups and the next time they're meeting. And it's lengthy. If anyone is interested in that, the easiest way is to go to the calendar, events and meetings. But if you also would like a digital copy of a list of them, put your name and email in the chat and we'll send it off to you. Okay, Bill.
Okay, it's 4 o'clock and we are now going to overtime.
And I didn't explain overtime. Overtime is just a lot of people want the social aspects of this, and we just decided to leave the Zoom meeting up. Bill is going to go ahead and start drinking now, and so he's not going to be with us, but the rest of us can stay, whoever wants to. A lot of people just like to say hello to whoever's on that they haven't seen in several months or whatever. But it's just a free time. We're just leaving the Zoom channel up. And so,
Glenn, you had your hand up, so you may want to stay, or you can go ahead now and say what you got going.
Yeah, I
Yeah.
will certainly stay, and I will field questions that people may have too. I wanted to mention, I just put it in the chat, I really empathize with Rory in terms of his diagnostic journey, especially because yes, the average Sjogren's patient is usually a younger Nordic woman, so I can imagine what you had to go through to get that investigated. But your story and many other people's brings up something I think it's very important in terms of diagnostic journeys, and that is that if at all possible and your insurance will allow it, you really want to try and get into a tertiary or research center for this. There are so many potential causes of neuropathy and so many presentations. You really need the best expertise you could possibly get. And generally that means a place like Johns Hopkins, Cornell Weill in New York, Massachusetts General, the Jack Miller Center in Chicago, University of California, San Francisco, all very, very much big neurological and neuropathy centers. It's definitely true, as our presenter said today, that about a third of all neuropathies are idiopathic, but it turns out a lot fewer of that tend to remain idiopathic if you're at such a center. They tend to look into much more obscure causes. And I will beat the drum a little bit for this. I will be doing a webinar sometime in the late spring or early summer, it depends on scheduling, about obscure neuropathy causes that should be tested for if the usual stuff doesn't pan out. I will certainly post that, in all of the groups, and you'll be able to find it at the Western Neuropathy Association website as well.
Thank you, Glenn. Thank you. Meredith, you have your hand up.
Yes, I just wanted to thank you, Rory. You just got a tremendous amount of strength. I really appreciate your sharing. And I missed the very first thing. Did you say you were first diagnosed with MS? I missed the very first label.
Oh, the first label was CIDP.
Okay, we're in overtime. You got 5 minutes to go.
Peggy Barton, go ahead, please.
Blow a
Okay.
whistle or something?
I would love to find a subspecialist doctor around Boston area. In fact, I have a wonderful one, but you can only see him once a year because he's so much in demand. So it's a little nerve-wracking when you're getting worse, as I am, and I can't get in to see him. So I would just love to find somebody else I could second guess with and investigate with.
Have you been through the Mass General system, Peggy? Because that in the Boston area, that's where I'd go first.
That's absolutely where I kind of didn't start, but when my local doctor said, okay, I give up, go on to Rotten, I started in with Mass General, and the doctor's affiliated with Mass General, but he's so damn popular and precious that you can't get in to see him. So I just, I'm kind of at a loss right now. Anyway, I'd just like to see if there's anybody else possible that I could have as a backup. So anyway, that's what I'm trying to do.
Good. Somebody on here might know. You never get.
What about asking that doctor if he has an associate who sees people more frequently?
I already asked him, and no, he doesn't. But his secretary said he's in the process of acquiring a nurse practitioner. So as soon as he does that, I'm going to grab her. But I don't know when that will be. But that's a good question. That was my first one. But
Peggy, you might ask to be put on the waiting list for the.
Oh, I'm on the
PA.
waiting list, which is kind of a joke. It's like 200 people ahead
No,
of me.
I mean for the PA, you could maybe be first.
I did.
Okay.
I did. I said, put me on.
Okay.
So I'm just trying every avenue to get some more input. Thank you.
All right. Well, it looks like we have answered everyone, or at least anyone who had their hands up. Timothy Chapman, one last, you get the final word.
Well, thank you very much. I appreciate it. All these events really are great. and I'm happy to be here. I am in the Los Angeles area. I'm with Kaiser at another meeting last month, I believe it was. I talked with Glenn, and Glenn, you said that it sounded like my neurologist in Kaiser. Kaiser didn't seem that curious to look into causes, and they diagnosed me as having idiopathic neuropathy. Well, I got a referral to what they refer to as a neuromuscular, I think a neuromuscular clinic. And I think you said that would be that would probably be a better move. All I know about it is that they referred to it as the Neuromuscular Center in Los Angeles.
Yeah.
And I was wondering, when people were discussing, sorry, I don't have my video on. I didn't realize. Hello. When you were discussing this more specialized centers, would that count as one of them, or is there another one out here in California that I should be looking at?
No, you're probably in fairly good stead, I would think there. You generally do want people who have neuromuscular specialties. They're more likely to be versed in neuropathy and the conditions that cause them, I would think.
Okay. All right. Well, I have an appointment coming up this month. It's a video appointment, but we'll see what happens, and hope something good comes from it.
Bill, as a final comment, I'd like to tell everyone that our March meeting will feature a spokesperson from a mobility clinic, and he will be hopefully showing one of our members around his store. It's not a clinic, sorry, store. And he will be showing things like scooters, rollators, lift chairs, just what he has available. I was amazed that they not only sell, but they rent equipment. They do cleaning and sanitation of equipment that you own. He has a whole lot of options available to the public that I didn't realize. So I think it'll be an interesting meeting. He's located in Alexandria, Virginia. And as I said, one of our members has agreed to be the customer and go around the store with him to understand how his equipment could help her. Thank you.
Thank you. We got 5 more minutes. We're behind by 2.
Linda's got her hand up. Laura's got her hand up.
Go ahead, Laura.
Thank you. I just wanted to find out. I've been to several neurologists and they all say, yes, they know about peripheral neuropathy. I have had no good results whatsoever. I finally asked one of my favorite doctors and she said there really isn't one in the area. So how do you really know if they know anything? Because I'm up there in age. I can't drive more than 10 minutes because my feet go numb, or that foot, and a driving foot. So I have to have somebody take me, and I don't want it to be in vain. If I have to go to Philadelphia, because I'm in Allentown, that's about a little over an hour, to find the doctor. But I don't want to just go and then start going over and over and over without getting someone who really knows.
Hey, Glenn, do you want to answer that?
Generally, if you're looking at the credentials for these people, you want them to have done a fellowship in neuromuscular conditions or have done it at a major neuropathy center. And as I said, these include places like Cornell Weill in New York, Massachusetts General, the Jack Miller Center in Chicago, which is affiliated with Northwestern, obviously Johns Hopkins, Mayo Clinic, University of California, San Francisco. I don't know of any like offhand in the Philadelphia area, and even though it would be a trip.
That would probably be my only, because I live alone and I have to, get somebody who would take off work and, take me. And it's so far, all my endeavors have been in vain. in trying to really get, the last one gave me one pill that made me very heady, foggy, dizzy. And he goes, well, that's it. No exercise, no advice, no nothing, you know.
Yeah, which is not great, unfortunately. You know, a lot of the neurologists out there, they've heard of neuropathy, but the ones who tend to treat patients more with stroke or MS or things like that don't really have the expertise.
No, I do ask that when I make the appointment, I do ask, I said, this is strictly about that. I want to know if he doesn't have to specialize, but he has to know. And I know I got a little bit forward with that, trying to, you know, insist on it, but it was to no avail.
You're in a world with very little acknowledgement of the existence of peripheral neuropathy. You have to be your own pusher, your own advocate.
Oh, I know I have it.
Yeah,
and it's progressing.
I would,
but yeah.
That's one of these groups are so important.
But I would
exactly
say a couple of things. Pain medicine, if you've got serious problems with pain, not everybody does. If it's really impacting your life, don't take no for an answer. Say, got to do something about this.
Well, I'm on CBD, and that cuts it almost in half.
Oh, good.
But it's
You got it under
progressing.
control.
Yeah.
But secondly, don't give up on driving. And the way we don't give up on driving is you investigate hand controls. I have hand controls. Several of the people on this sport group have hand
Heard
controls.
of, yeah.
And put a lot of effort into it. Yeah, you got to get trained. Yeah, and you got to go to the whole business. There are businesses in the business of providing training and providing.
Who would that be? Who would that be?
Well, there's large corporations. I don't necessarily recommend them, but they'll get the job done. There are smaller businesses that do this. I have no idea what's available in the Philadelphia area.
Yeah. Okay. Thank you.
Laura, be very careful, because one of the members in the Pittsburgh group's husband decided that he thought he might need hand controls. He went to one of the places that sell them, and they said, well, we need to do an assessment. So they did the assessment and he failed. It gets turned over to, got turned over to the state in Pennsylvania. And I thought that was outrageous. That was not transparent at all. And so then he was stuck with either getting the hand controls, or B, driving. And if he was involved in an accident, it would be on the record that he had failed the test. So be very careful.
Thank you for saying that. Thank you. That's very helpful. I'll be very cognizant of that.
Even before you go, when you call, say, now tell me about the assessment.
There you go.
Who gets a record of it? What are the implications? Because they presented it as if it was just part of whether you needed it or not. And when he failed, that's when they found out.
No, I would have no idea. And you even know about the state. So thank you.
Yeah.
And that just happened in Pittsburgh.
Yeah,
Glenn, I have one last thing to ask you. Can you put up, or where do you have a list of those centers? I mean, you can reel them off, but where could we find them?
Right.
Actually, most of them are on the Foundation for Peripheral Neuropathy website. You can really see them there. And by the way, thanks for mentioning what you just did, Pat, because it's a very important consideration with hand controls. I will actually say this is not a coincidence. WNA did a webinar on hand controls and driving just this past January 26th, which should be posted to our website within a week. So people can hear about it.
Because I looked for it and I couldn't find it.
It unfortunately takes our tech people too long by my standards to get it up there, but it should be up in the next week.
Okay.
Okay, thank you.
We should point out that Glenn is a big deal with the Western Neuropathy Association, but he's east of us, most of us. He's out of New York. So I don't understand, but never mind.
Western was originally California, Oregon, Nevada and stuff, but in the aftermath of COVID, with a lot of things moving online, we consider it now just the Western Hemisphere.
And he's in charge of world domination.
Well, we consider DC the center of the world, you know, so.
See, now we always think New York is, so, you know. But yeah, but we certainly have people now from around the world, you know, so it's a bit of a misnomer.
What is the place in New York what is the best place in New York? I might get my grandson to take me there.
Absolutely, the New York Presbyterian system, which includes both Columbia and it also includes Weill Cornell. The only difference between those two is that Weill Cornell is Midtown Manhattan and Columbia is Uptown near the George Washington Bridge.
Oh, okay.
But they share resources.
Laura, by coincidence, my son-in-law is a radiation oncologist at Columbia. I could ask him if he knows of a neurologist that he would refer people to.
It's a very good idea. Thank you for sharing that.
And if you will put your email in the chat, I will send it to you.
Oh, that'd be great. That would really be helpful.
Okay, Peggy, you had your hand up?
Yeah, it's about something Laura said. I think she said she's on CBD to help with pain. So I wonder if we could sometime talk about that to see if it helps with sleep. I'm thinking of, I did get a medical marijuana card, but I haven't used it yet. So I'm just seeing if it may help with sleep or anything else. So just to hear what other people have to say about it sometime.
Let me just
Peggy,
comment.
Peggy, we had a panel on medical marijuana use, and if you go to the website, go again to events, past calendar.
Okay.
And just search marijuana and it should come up. If you have trouble, email us.
Okay, thank you.
Peggy, I'll tell you something about, I've got my card also, and one thing that I found out is you need, when you go to a marijuana center, you need to talk to the person one-on-one about what you have, what you do, have a little journal, and have them, you know,
Custom adjust.
You need to talk to a professional behind the counter.
Okay.
They do all have someone in the back. He might be out that day, but usually there's a professional, you know, a nurse or a doctor or somebody who's in the know.
And just walk in and say, look, I've told I got to talk to the manager. I've got to talk to your professional. I mean, some of them are like shoe salesmen and they have no idea. You need to say your doctor told you to find a person who knows what they're talking about.
Before I even go, I'll call up and ask them about somebody. Thank you.
But as Pat said, we did have a panel on it, which was excellent, but
can we do it again?
Gives you some great ideas to, you know, what to ask.
Okay, thank you.
But you need to talk to the person and say, look, I've got this and that, what do I need? And well.
Wonderful.
The problem is all the states have different laws, so it's tough to figure out something to say about it that's universal. But anyway, that's not a reason not to have one.
And your doctor who gave you or signed off for you to get your card must have some ideas about people where.
Exactly. I'm going back there to him. David Gordon was the one that gave me the card, but nothing else. But he has to have some connections for his position, right?
Well, you should ask. Yeah.
You know what? Massachusetts is so on top of this now. I didn't even have to go to a doctor. I went through this system online where it was called Med Health, and somebody calls you up and you talk to them on the phone, and I guess it's a nurse, and boom, I had the card within an hour, a temporary one, and then it got sent. It was almost too easy, but
well, they're from state to state. They're all different.
Yeah, but the thing is, you get it very easy. Sound probably, you know, but still, when you get it and it's official, you need to find the pro behind the counter.
I will. Thank you.
That's my advice.
It really took. Sorry.
Oh, sorry.
I just want to say it took me 3 years to actually find the right product for pain relief during the day. Where it was a trial and error, trial and error, trial and error.
I
So-
never realized there were so many versions of marijuana. I'm getting all these emails about this for that and little updates and, oh, you might want to try this weekend, and ridiculous.
Well, like I said, we had a panel and the panel was excellent and I forget the name of the guy, Paul. So anyway, he recommended a certain brand and then somebody else. It's just, again,
Okay. I'll watch it.
but if you go in with the idea of knowing something and they know you know something,
Oh, yeah.
Right.
they're
Oh, yeah.
going to start being more knowing.
I'll tell them I'm an
Or
official.
helpful, yeah, yeah.
I'll tell them I'm a top-notch pothead and they can't fool me.
Well, don't be a pothead, just, well. Linda. Linda, did you have your hand up? Pat.
Pat.
Was it Laura or Peggy who wanted the reference to Columbia?
I did.
Laura, okay,
Yes.
if you send me put your email in the chat for me, please.
Okay, sure. Thank you.
I have
All
a
right,
question.
Susan.
Okay,
Susan?
I want to ask Pat a question. I was very interested in what you said about your sister's neuropathy being tied in with gastric problems.
Yeah.
That may be what my sister has. She's got neuropathy, she's got it, but she also has horrible gastric problems. Nobody can seem to figure out. Is there a name for that?
Well, you should go back and listen again to Dr. Eicher's response. It's basically, let me I wrote it down, dysautonomia.
Yes.
She has diabetic peripheral neuropathy, but now they're telling her that she may also have help me, Glenn. The central.
Are you talking autoimmune or are you talking?
Yes. Well, I honestly, I hadn't thought I was going to talk about this and I can't remember what they called it.
Is it autonomic dysfunction?
Autonomic dysfunction?
Like you're like your sister, they have done every test. They can't find any reason for the gastric pain. She's in misery. But they said it's autonomic neuropathy, not peripheral, which affects the organs. Is that correct, Glenn?
Yeah.
Okay.
Yeah,
So-
and by the way, autonomic neuropathy is not uncommon in diabetes and in other small fiber syndromes. I made a comment.
Dr. Eicher said, yes.
Yeah.
But nobody's prescribed anything for her other than Miralax. I mean, that's no answer. That's not helping the pain. So if anybody has any suggestions, I would love to hear. Dr. Eicher suggested that there is medication that would treat the GI along with the diabetic neuropathy, but no one has suggested it and she didn't name the medicine. So I don't even know what to ask. So
Okay.
Dr. Eicher did say she would send a list of autonomic dysautonomia centers, and I don't think she ever did. I think maybe she forgot. So another follow-up question for her.
Okay, I'd like to have a copy of that too. I don't think my sister has ever been to a neurologist. I went to Johns Hopkins and I was treated pretty dismissively. Told to go away and don't come back for 3 years. I don't think they did a biopsy. They just did the EKG thing. And so I think after my bad experience, she said she doesn't like going to the doctor anyway, but she's got all the same symptoms I have. So,
wow.
Except for that one in the gut. Okay, finish.
Well, if I find out anything more, I will certainly share it with you.
All right, thank you.
Pat, does she get nauseated and bloating and that sort of thing? Because she did, Dr. Eicher did mention dysautonomia, which I think is what is that? I was looking it up. It's the non-voluntary body functions like heart rate, sweating,
Breathing.
blood
Organs.
pressure. Yeah, and I have a lot of gastric stuff, so I'm gonna look into that. If I find something, I'll let you know.
Okay, thank you. I mean, they've done all the checks for tumors and all of that, and everything comes back normal. So she has no reason for the pain and no treatment either.
That's awful.
I don't happen to know off the top of my head, Pat, a lot of medications that would treat both. I'd be curious if you found out. There are medications for dysautonomia to help with those particular symptoms, and obviously for other neuropathy symptoms, but usually it's a polypharmacy situation. People take a number of different things.
Okay. Well, if we could even find a center for a doctor that would talk to her, who had some knowledge, but she hasn't found a doctor yet that's really done anything to help her.
It's surprising in a way because autonomic symptoms are so common with small fiber syndromes that it's something like, I know at discussions we've had at Cornell, it's a constant, consideration. A lot of the time, not in your sister's case, a lot of the time the symptoms are more minor. They're often described as subclinical, but I would guess that at least half to 2/3 of the people with small fiber syndromes have some sort of disruption either in blood pressure, gastric motility, sweating, all of these, of course, autonomic things, even in adrenal function, believe it or not. It's just that the autonomic nerves, which for the most part are small fiber, just are not functioning correctly.
Well, she's working very hard to get her diabetes under control and hoping that helps, but nothing's really doing anything at this point.
Well, I've got to go outside and search for Chinese balloons. So I don't know what
It was already taken down. They're looking for the debris.
Oh, is that right? Who took it down?
I think so.
We can't do any politics. Don't do any
Oh,
politics.
no. Oh, that's political?
Yeah, politics. Thank you, Rory, for that reference to the Dysautonomia Foundation.
Yeah.
Good to see you.
You're welcome.
I've got to sign off, and this is my first overtime, and I love it.
But I can,
Very helpful, very helpful.
we can leave this up if people want to chat. I mean, it's just the channel is open, and then I can come back later and shut it down. So help yourself. I really appreciate all you guys. It's great to see everybody.
It's really
I
good.
agree.
Don't
Peggy-
forget to save your chat. There's
Peggy,
a
I
lot of
keep-
information, especially this meeting.
Peggy, is
you
your
go.
hand up? Is your hand up, or did you keep?
No, my
Yeah.
thumb was up saying, good job. Thank you so much.
Okay.
It's the thumbs up sign.
All right, I'm leaving. This has been great.
Can I just ask one question really quick?
Yes.
Of
I
course.
went to save the chat, like someone said, and I
Yes.
can't find the file.
Oh, that's about normal.
Yeah.
Oh, really?
Are you on a Mac or a PC?
PC?
PC. Oh, boy. So
I can't
would
help you with
say-
that. I have a Mac.
Yeah, well, they both are terrible. It creates a folder called Zoom, and everything about this meeting is saved in Zoom. So any of those automatic files. So if you search on Zoom for a folder, that's where it'll be. It's way down in the bowels. It's in the basement, and you have to go down there and extricate, the file. But
Well, I do have a folder called Zoom. In it, I've got some subfolders, but I couldn't find.
Yeah. Well,
I couldn't
check on the one with today's date.
That's the only thing you can go by because you have to rename it. So look for
Okay.
today's
Yeah.
date.
And
On the
if
Mac,
you-
on the
I'm gonna
Mac, it
post
shows
the
in the Finder.
Yeah. I'm going to post the chat on the website anyway. So if you can't find it, it'll be there. So
Okay.
at least we'll have it.
Okay.
Glenn,
All right.
Glenn, can
Thank
I
you.
get an email for you, Glenn?
Yes, absolutely. I'll put it into the chat.
Okay, great.
I'm
Thanks.
surprised more people don't have it already. 'Cause I sent it
Yeah,
out.
I thought everybody had it.
Oh, there it is. There it is.
And a lot of them have my
Haven't even got
phone
your phone
number as
number, so
well.
watch out.
Yeah,
We
no, I
found
won't.
everybody.
Oh, believe me, I get calls all week, so.
Do you want a car warranty?
That's a side hustle. Yeah.
Anyway.
I see. I see.
By the way, is dysthymia, is it spelled D-Y or D-A?
DYS.
It's
Oh,
D-Y, right? Okay.
DYS,
Yeah,
dis.
someone has D-I-S-A. Well, okay.
Yeah,
I thought
Rory
it was
spelled it in the chat.
D-Y.
Yeah, he has the foundation name in the chat.
Okay, I was just looking at, okay, I got you. All right, I swear I'm leaving.
I
I
hear
know.
you, Bill.
Yeah, it's hard to tear away. Isn't it? It's hard to tear away.
It's
Yeah.
almost 5
Very,
o'clock.
very helpful, very
It
helpful.
is, man.
We ought,
Support's
to
important.
we ought to start with overtime. And then go to the meeting.
Well, don't we? I
That's
started
true.
at 1 o'clock. I thought, where were you guys?
He
Hey, the
really
way
does.
The way I look at this today, it's only 22 degrees outside right now, so I'm not going anywhere, so.
My daughter is a dairy farmer in Maine. She
Oh,
was
God.
milking this morning at minus 18 below.
Oh, I'm sorry.
This temp is crazy. They had to move the chickens into the calf barns to keep them warm enough so they wouldn't freeze. So,
Oh, my goodness. I know
insane,
it's-
insane.
Yeah, it's really, really cold. Zero.
Loves it.
Yeah. Very cold.
Yes, here in the DC area, we have it really good. I mean, it was 17 degrees this morning when I went out and walked. I thought that was low. Now I think that's not so bad compared to your daughter.
Yeah, and we're at our high of 33 right now, so not bad.
The DC area has had it really good the last 4 years from my
That's right.
money.
Yeah.
Yeah,
New
we've missed a
England was
lot of
very
time.
problematic this morning.
We're at a 12 high in Hopkinton.
Of course, on the other hand, we're infested with politicians.
Well,
There you go.
so which one do you choose?
My daughter lives in Denver and it was 7 degrees. And last weekend she went to Steamboat Springs and they had they've had 300 inches of snow.
No way.
Where was that, Bill? Where was that?
Denver.
Oh, wow. Okay.
But
The skiing is good.
The ski slope was 300 inches of snow they've had.
Oh, my
So
goodness.
my daughter said they'll be skiing through August.
Well, they need to refill Colorado.
I guess they don't need those machines, huh?
Bye, Mike.
Hi, Mike.
Thank you.
Thank you all. See ya. I'm leaving. I really am leaving.
Okay, fine. Yeah.
But
I think I'm gonna go too.
I'm gonna suggest to the group that we start with the overtime first.
I like that. I like that.
I like that too. I'm there. I'm there.
Do the before
And
time.
just the few of you who are left, did you think it was okay to show the recorded presentation? I'm just looking for some
Yes,
feedback.
yes.
Yeah.
Great idea. She's
But it
very,
was-
very busy, so at least we got that, and she gave us great information.
But now we're spoiled because she's probably one of the best people we've.
Yeah, right. We'll never
That's
see
it.
one like that.
That's very true. Neurologists are not known for bedside manner or sense of humor,
Correct.
so.
Or not.
I will be writing to her to thank her, believe me.
Good.
Great.
Pat, I have been in this group how many years? This was the first time I had a simple, clear explanation of some of these things.
Yes, me too.
So
That's right.
understandable.
Yep, me too.
And
You
even
know, at
that
first-
diagram that she sent us, it looks daunting, but if you follow it, it says if you have these symptoms, go here. If you have these symptoms, go there. I mean, you should look at it. Don't be saying, oh my gosh, I can't read that. It's all, scientific
What's the
gobbledygook.
title?
It's-
What's the title of that?
Well, it's the
It doesn't
handout.
matter.
The
Just go
handout,
to the web.
when you go to
Our
our
web?
website and go
Oh,
to the
ours.
past events, go to Mary Eicher's meeting, which is April of 22. And
Oh,
she
okay.
has both the medication list and the diagnostic chart.
Oh, thank you. Okay.
Well
That
worth doing.
That diagnostic chart, by the way, is based on something known as the Poncelet Protocols, which was
Yeah,
written
I
by
saw
Anne
you wrote that.
Poncelet in UCSF back in 1998. There is a link to it in the chat, and
Wow.
you can pull it up in through the American Association of Family Physicians website, because in terms of like general approaches to diagnosing neuropathy, even though it's 24 years old, it's probably still the most easy to understand explanation that's out there.
So
That's
we
great.
don't need no darn neurology.
And I'll give you a hint that I learned. When people put them in the chat, click on it, have it up. After you finish the meeting, go back and say, oh, I want to save this one. No, this isn't what I thought it was. So like Glenn's references, I've already clicked on every one of them. So now when I'm finished this meeting, I'm going to go back and save the ones I care about and just delete the ones I don't. That
Sweet.
way, if you don't remember how to save the chat, at least anything that you thought was interesting during the meeting, you've already opened. And then you can decide whether you're going to save it or read it or discard it.
But the warning is the chat goes away as soon as we close this meeting. So
Right.
you either save it or you don't. And I'm
Well,
so,
I just
Oh,
want
that's
to tell
good
you,
to know.
Pat, you know, the last meeting, remember several of us, there really were not those dots to the right of the for several of us. There
Yeah.
was today. So I don't know if you guys fixed something or what, but it was great. So I was able to save it.
yeah, they should always be there. Pittsburgh's, for some reason, we don't have the dots for the Pittsburgh group. But
Yeah.
anyway,
I just keep updating my Zoom to make sure that I have whatever is the newest. That's
good. That's
the
helpful.
only thing I can suggest.
Oh, when you save the chat, where does it go?
Well, that's what Tim was talking about.
Right.
It goes in a folder called Zoom,
Oh,
and it's I can't tell you where it is on your
Do
computer,
you
but
have a PC or a Mac?
a Mac.
okay, so
on
it's
the
on your
Mac, if you-
desktop, and then it's on your hard drive, and then in a folder called Zoom, and then it's got a date on the file name.
It went onto my desktop?
Well, no, it's not on the desktop. It's from the desktop. It's if I try to explain it, we really
Susan,
Uh-huh.
you know the Finder at the bottom on your taskbar? The Finder?
I have a Finder somewhere. There it is.
Yes, it's the dual
Apple
image of two
F.
faces.
What?
If you click on that, that will help you.
or Command
It'll
F.
help you find your folder. Search Zoom folder.
Oh, okay. I go to Finder. It doesn't tell me to search anything. Okay, I'll play with it later. Thank you.
It's there.
And we'll post it on the website. Keep checking the website. There's a
Okay.
lot of stuff there.
Okay.
We're looking for readers.
And
Oh,
and
well,
given
there's Glenn sending me one more. Glenn, I've already saved. Don't send any more.
I threw that in there just because it's sort of a master document list. This is the base document that I created for the webinar of useful neuropathy websites. So if you save this one, then you have access to about 20 others.
Yay.
Okay.
So that should help.
Susan, I went to Finder and then I just went down the list to the Z's for Zoom and it was there. So yours
Okay.
should be also.
All right. Thank you.
Mhm.
I'll see you guys later. Thanks.
Me too. I'm
Thanks
leaving.
for everything.
Okay. Thanks, all of you.
I'm going to take
Thank you. Thank
Thank
you.
you.
Very helpful. Thank you.
care.
Leo.
Bye,
See you
everybody.
in March for mobility.
Yeah.
Should be interesting.
Yeah.
Bye-bye. Glenn, I'll see you at the support group leaders.
Okay. Here we go.